Hello, I'd like to welcome you to the first EURETINA Case Club brought to you from a virtual Moorfields Eye Hospital. And in this meeting, we're going to share 6 cases seen recently by the retina fellows at our institution. Sorry. Slide advance, please. So these are the august faculty who will be discussing the cases. So each of the cases will be a short didactic presentation, followed by a discussion with our faculty, Professors Alan Bird, Lyndon Dacruz, Catherine Egan, Omar Mahoo, Carlos Pavesio, and Jose Pulido. And Jose, we take as an honorary Moorfields consultant, having done a sabbatical here and regularly contributing to our teaching. But most importantly, apart from the faculty, are our fellows, and we're very fortunate to have a very international fellowship program, and hopefully the fellows that will present this case will reflect that. And we're going to start off with our first presentation, which will be Gabriela Grimaldi, with a case titled "A Penny for Your Thoughts."
Good evening. I would offer a penny for your thoughts on a 37-year-old man from Colombia. Our patient was born in Bogota, where he spent the first 14 years of his life. During childhood, he was diagnosed with umbilical hernia and appendicitis, and he had surgery for both. And he was first noticed to have problems at the back of his eyes at the age of 7, described as intraocular scars from chororetinitis, in the context of very good vision. The decision was made at the time not to intervene in view of the absence of symptoms. Our gentleman moved to Canada at the age of 14, where he was diagnosed with diverticulosis as a teenager, and he was noticed by a local optician to have white linear lesions to the retina, which were felt to be possibly secondary to old inflammation in both eyes. His vision remained pretty good, so the decision was made at the time to continue to observe with annual reviews. Our gentleman then moved on to the United Kingdom, which is where we met him in person just last month. He attended the optician complaining of right worsening of floaters for a couple of days and was sent to A&E to rule out any retinal tears or holes. In A&E, he was noticed to have slightly reduced vision on the right side, good pressures, and an overall unremarkable anterior segment examination, except for right mild vitritis. On fundoscopy, he was noticed to have a right prepapillary bleed with inferior exudation. In the left eye, there was some grayish material in front of the disc with exudation superiorly and inferior temporally to the disc. Ultra-wide imaging showed that the vascular problems were not limited to the posterior pole, as there was extensive vascular sheathing observed in the retinal periphery alongside some dot and blot hemorrhages. Similar findings were noted in the left eye. Autofluorescence did not seem to show any remarkable feature except for possible slight hyperautofluorescence around the disc. On fluorescein angiography, we can see that there is extensive capillary dropout at the level of the periphery in the right eye, with some possible vascular problems at the level of the disc. In the left eye, similar findings with extensive capillary non-perfusion in the retinal periphery. On late frames, we can see that the left eye shows disc hyperfluorescence, whereas in the right eye, the disc abnormalities become somewhat more apparent in the later frames. OCT angiography confirms this finding and shows that the peripheral capillary non-perfusion tends to dive towards the posterior pole temporally. And if you look at the optic disc, the blood vessels that exit the optic disc look somewhat engorged and enlarged with an abnormal configuration. Indocyanine angiography shows normal choroidal configuration, but at the same time, if we zoom in at the level of the optic nerve head, we can see that those vascular irregularities become somewhat more apparent compared with the fluorescein frames. This is all the more evident on the late ICGA scans, where we can see hyperfluorescence corresponding to vascular outpatchings at the level of the disc. If we take OCT scans with enhanced depth imaging through these lesions, we can see some enlarged blood vessel on the top left, some intraretinal exudation, bottom left, some intraretinal exudation and enlarged blood vessel on the top right, and some prepapillary hyperreflective material on the bottom right. Now, if we go back in time to 2003, we are lucky enough to have the scans from that time in Canada. Now, if you remember, at the time it was described as wide linear lesions to the retina on both sides, and these wide linear lesions correspond to the peripheral vascular sheathing which was present at the time. If we zoom in at the level of the optic disc, we can see that at the time there was selective widening at the level of the arterioles coming out of the optic nerve head on both sides. On subsequent scans, there was no big change except for possible changes in the vascular configuration at the level of the left optic nerve head up until 2021, when we met the patient in London. So, could these be developmental, for example, FEVR? Now, the genetic testing is pending, but there is no family history. Could these be infectious or inflammatory, for example, vasculitis or sulcate, syphilis? But all blood tests that we requested came back normal. Could this be idiopathic retinal vasculitis, aneurysm, and neuroretinitis? It could fit. Is it currently active? After all, we noticed the presence of new hemorrhages, exudates, and disc vascular lesions that were not observed before. And if it is, should we do something about it? Should we observe? Should we laser the periphery? Or should we consider intravitreal anti-VEGF? Once again, I would really offer a penny for your thoughts.
Great, Gabriela, wonderful presentation. If I could possibly ask Kathy and Professor Alan Bird to maybe make some initial comments on the case, or a penny for Gabriela's thoughts.
Well, thank you very much. I'll defer to Kathy. I mean, it's just that it obviously doesn't look like exudative vitreoretinopathy. The periphery is wrong. So you've got the trunk, you've got the closure in the periphery, and there are some there's some aneurysms on the disc, but I don't see anywhere else. I don't think that excludes IRVAN, but IRVAN seems by far the most likely. As to management, I'd leave it to others to tell us what their experience is.
Thanks, Alan. I think that's a really nice summary. The key finding here for me was the aneurysms on the first order arterioles. The interesting thing in this one is that the peripheral ischemia is very long-standing with no consequence, and he's not developed any neovascular consequences over a very long period of time, most likely. So we could bring in, at this point, we've got two inflammatory disease experts on the panel. We've got Jose Pulido and Carlos Pavesio. We could bring them in to think about the possible inflammatory cause of this. In fact, this is Carlos's case. So perhaps we could ask Jose whether he would consider a differential for aneurysms, an inflammatory differential for aneurysms affecting the first order arterioles.
Thanks for allowing me to participate. And I'm really interested in the fact that he's had this diverticulitis, and Crohn's disease can be associated with a granulomatous disease. Now, when you think of the fact that this person's had problems since very young, so a young person's Crohn's disease, I would consider something like Blau syndrome, and we've actually seen macroaneurysms on vessels and published in patients with Blau syndrome. So I would throw that out there.
So Jose, I think that's a great thought, but first order aneurysmal changes could occur with anything. I've not seen it with Blau's or sarcoid, and I've never quite understood why you get multiple macros in sarcoid when it's predominantly a phlebitic disorder, but we still get it. Going back to the problem that Gabriela raised, which is the hemorrhage and exudate. The exudate is slightly difficult to explain. It could be small vessel leak, but there is still not a PVD. Looking at that OCT through the optic disc, the vitreous is still attached to the vessels. You showed us the beautiful close-up OCTs. So the question is this a progressive disorder or is this a secondary tractional problem now? Because there is the management problem, there's a diagnostic dilemma and a management problem. And Irvan can go very, very much, we don't really have a treatment idea or paradigm to do this, but sometimes just burns out with no treatment. So Carlos or Jose, is this just burned out Irvan? Or what's the mechanism for bleed and exudate?
Carlos?
Yeah, no, just the point about this, that and if you look back at our experiences in others as well, immunosuppressing these patients with steroids doesn't seem to really make a difference. These continue to progress. And your concern is the progression of the capillary dropout. So you can see this actually invading the vascular zone over time, and that's how they lose central vision. So the exudation is important, but the ischemia, progressive ischemia, is also important. It seems that lasering these patients early on with the areas of ischemia seems to be an important way of trying to reduce this rate of progression. And that's what I have been trying to suggest in patients who present this way. You're not lasering because you can see new vessels, but you're lasering because you might be interfering in the way that these, you can imagine there's going to be VEGF in this eye definitely floating around in large amounts. And it might be a reason why you can see further vascular damage occurring. It may not be as much as we've seen other conditions inducing new vessels, but it may be enough to be causing more disruption. So what my advice usually is laser everything you can of the affected areas, and because immunosuppressing them with any other way doesn't seem really to make a difference.
So so given there's large area, are we sure, Gabriela, there's been recent progression in the area of capillary dropout?
Well, what we can be sure of is that the hemorrhages and the exudation are new or relatively new, because we've got optician pictures from last year which show that those findings were absent. As for the capillary dropout, that's difficult to tell.
Okay, so so usually the reason you laser is because Irvan patients get secondary neovascularization, which is not clearly the case. But on the other hand, you feel more comfortable doing it. But the question is still Gabriela's, why the hemorrhage and the exudate. Any thoughts, Gabriela, because we only have a short time before we need to go to the next case. Any thoughts about what you thought was the mechanism?
Well, I felt that there could possibly be an element of traction on the right side, because that's quite different between the two eyes, and that this hemorrhage was probably related with some traction and splaining the floaters. Otherwise, the exudation and the papillary changes could probably be more long-standing or related with possibly changes in the vascular configuration. So yeah, probably Pavesio's idea of lasering to prevent these from spreading further to the posterior pole would be a sensible idea.
So we'd love to discuss this further. We now need to move on to our second case and a change in direction, and Pilar Martin is going to present that not everything is as it seems.
Good evening, everyone, and thank you for allowing me to present this interesting case titled "Not Everything is What It Seems." A Caucasian 73-year-old male came to the genetics clinic in Moorfields Eye Hospital accompanied by his daughter. His visual acuity was 636 in both eyes. He had been previously diagnosed with retinitis pigmentosa, RP, at the age of 13 and had been referred to Moorfields from his local hospital for genetic testing. His main complaint was decreased central vision since childhood, which did not improve with glasses, as well as dark adaptation, night vision, and peripheral vision problems. He felt that his peripheral and central vision loss had progressed over the last few years. Due to poor central vision, he could never drive, and apart from hearing problems in adulthood, likely related to his job as a vehicle engineer in hemochromatosis, he was fit and healthy. These are the patient's pseudocolour fundus pictures and autofluorescence images, showing pigmentary and atrophic changes in the retinal mid-periphery, with an abnormal fundus reflex in both eyes. OCT scans revealed loss of outer retinal layers in both maculae, affecting fovea. His family history was such that 4 maternal cousins are also affected with a similar condition. The pattern of inheritance in this family seems unlikely to be dominant due to the lack of other affected generations. Autosomal recessive inheritance may be possible, but given the lack of affected females, X-linked recessive inheritance seems the most likely option. Because X-linked RP carriers exhibited a P2 retinal reflex, we examined the daughter. The daughter's examinations showed no signs of RP carrier state. She told us that she has a son and a daughter, and that his son was recently seen in the pediatric genetics department in Moorfields. The patient's grandson, who also complained of poor central vision, had been seen in his local hospital since the age of 2, given his family history of X-linked RP. These are the pseudopolar frontal pictures images and autofluorescence images of the patient. There seems to be a spot of hyperfluorescence in both eyes centrally. OCT scans revealed bilateral cystoid macular edema. The grandson's electrophysiologic testing showed no evidence of generalized cone or rod dysfunction. Bilateral cystoid macular edema in a child could make us think of X-linked retinoschisis. This is commonly associated with an electronegative waveform in the standard flash EIGs. This was not present in our case. Bilateral cystoid macular edema can also be found in patients harboring a CRB1 gene variant. However, the pattern of inheritance of this genetic condition is autosomal recessive, which does not seem to fit with the family pedigree. Genetic testing of the grandson revealed a missense variant in the RS1 gene, which was also found in the grandfather, thus confirming the diagnosis of X-linked retinoschisis in both patients. X-linked retinoschisis typically exhibits reduced central vision and retinoschitic changes in the macula, which can become atrophic over time. However, a number of different features may also be present, such as peripheral schisis, macular changes, metallic sheen of the periphery, pigmentary disturbances, and vitreous veils. Although X-linked retinoschisis typically shows an electronegative waveform in the strong flash EIGs, it has been shown that in some patients with missense variants, like the case we just showed, may have less severe or even normal responses, whereas nonsense splicing site or frame shift variants may exhibit more severe electrophysiologic alterations. A reduced V wave in the bright flash EIGs implies reduced inner retina function, which may explain the night vision problems in a 73-year-old patient. As a take-home message, it is important to remember that the phenotype in X-linked retinoschisis can be highly variable. Normal electrophysiologic testing does not exclude X-linked retinoschisis, and CRB1 must be included in its differential. Many thanks for your attention.
Thank you, Pilar, for a great presentation. Omar, maybe I can ask you about some comments. And so the sensitivity of electronegativity in this context, what's your thoughts and approach given that case?
Yeah, thanks very much. And thanks, Pilar, for presenting that. Pilar's our superstar from Salamanca. All of our presenting fellows are superstars. So yeah, lots of learning points in this case. And your issue of electronegativity, I think when an ERG is electronegative, it's a very important sign, and it really reduces our differential of associated genes in the context of genetic disease, and even in acquired disease, it makes you think of certain diagnoses. But one learning point here is when you don't have an electronegative ERG, it doesn't necessarily exclude certain diagnoses. So with the other classic genetic causes, congenital stationary night blindness, where you invariably get an electronegative ERG, but with X-linked retinoschisis, the other main, you don't always get an electronegative ERG, and sometimes you just get a reduced B2A ratio in some of the missense mutations, and rarely it can be within normal limits, like in this case. And I think clues to this person's diagnosis were his central vision was affected first. So he carried this diagnosis of RP for however many decades, 60 years, I think. But his central vision was affected first, which doesn't really happen in RP. It should be the night vision, and then the peripheral vision, and then finally the central vision. So that would have been a bit of a clue. His OCT looked kind of diffusely thinned rather than just the outer segment loss you get in RP. The sheen you can see in X-linked RP as well as in X-linked retinoschisis, so you get a bit of a sheen in the periphery, so that doesn't necessarily narrow it down. And I think the family history is important. Whenever you see maternal male cousins related through, the mum's sister, then you should think of X-linked disease, or a maternal uncle, or a maternal grandfather. Not a maternal grandfather and a maternal uncle. I got a case sent to me as a query X-linked disease, and it was the maternal grandfather and the maternal uncle were affected. And if you think it through, the grandfather couldn't have passed it to their son, so in that case it wouldn't be X-linked. So that's helpful here. And then you say, well, there's no treatment anyway, is there a difference? Well, there is a difference, because we do have treatments emerging, so getting the right diagnosis is helpful, and counselling in terms of risks of passing it on. If we're sure about an X-linked pedigree, then we know what the inheritance is, but X-linked RP can affect females, whereas X-linked retinoschisis doesn't. So yeah, quite a few learning points here. Prof Bird is on the panel as well. Do you have any comments?
Well, I've got little to add, except we have had a male in his 60s presenting just with well-defined atrophy of the fovea and nothing else. And there was nothing to suggest X-linked schisis until we looked at his grandson. And then the diagnosis became clear, the grandson having normal vision at the time. The other thing, it is quite variable. I've seen one male in his 40s with 6/9 vision still. So it's quite variable in severity.
So Omar, the autofluorescence on the original patient that they saw is not, I mean, I must say I would not have picked it on that in a million years. If you didn't have the rest of the family history, is it you're getting to the point where you just, and it wasn't electronegative, you would just do the gene panel now?
That's right, yeah. And in the UK, we've now moved to whole genome sequencing for everything.
Yeah.
Even X-linked retinoschisis, when you could have just done one gene. But yeah, with the retrospectoscope and with the grandson, it becomes easy, and then you see all the signs of X-linked retinoschisis in this individual. But yeah, fresh, looking at that, you wouldn't have, it's not screaming X-linked retinoschisis. The sheen can be there in X-linked RP. The rest of him doesn't look like X-linked RP. That should be a lot more severe. TTLL5 associated retinopathy can give you a sheen as well, but that just gives you a problem in the center rather than this widespread. So this area of pigmentation, you can see why they diagnosed it as RP. That was quite reasonable, especially in the absence of ultra wide field imaging. Probably that was all you'd get on the image, and you'd think this is a patient with RP. But looking at it, you can see the distribution's a little bit funny. There's nothing temporally. We have a few patients with sexual RP where it's more inferior than superior, but this weird sort of nasal crescent is a little bit odd. So it, nothing about it was definite for X-linked retinoschisis, and really the family history and the grandson helped.
Yeah. So thank you, Pilar and Omar. Fantastic variability of that case. And we're going to move on now to the next case, which is Ilaria Testi. And her case is when defenses become attack.
Is about a 56-year-old Indian male, moved to the UK in 2012. He complained of right eye progressive visual loss over the last week. His past ocular history was unremarkable, and he reported a weight loss of 21 kilos in the last 4 months. Otherwise, he was systemically well. Best correct visual acuity was counting finger in the right eye. Fundus examination show a yellowish subretinal lesion surrounded by fluid with optic disc hyperemia in the absence of vitreitis. Left eye was unremarkable. This is the EDI OCT showing a homogeneous hyporeflective lesion in the choroid with subretinal and intraretinal fluid. FFA show early hypofluorescence with progressive increase in hyperfluorescence given the accommodation of the dye in the subretinal space. And ICG show early and late hypofluorescence given the full thickness nature of the choroidal lesion. So at this point, we are not presenting a diagnostic dilemma. I think that considering the origin of the patient coming from India and the yellowish subretinal lesion, most of you have already understood that we probably are dealing with a TB granuloma. So the patient was sent for quantiferon for chest imaging. He was starting on prednisone, 60 milligram a day, considering the right eye visual acuity, and he was also referred to a chest physician. Quantiferon came back positive as expected, and chest CT showed a mediastinal lymphadenopathy with also a granuloma in the left upper lobe, as you can see here. So at this point, ATT was started, and the dose of prednisolone was increased to 120 milligrams a day, considering the increased plasma clearance of prednisolone by rifampicin. So this is 1 week apart, and you can see how there is a reduction of the subretinal fluid surrounding the lesion. This is not the effect of the ATT, because he was starting on ATT only for 1 week, but this is the effect of the steroid. And the EDI or CT showed that actually it was not only a reduction in the subretinal fluid, but also in the lesion in the choroid. However, when we review the patient after 4 weeks, you can see how the lesion has increased. And at the review 4 weeks after, there was a further progression of the lesion. So at this point, we were considering 2 possible options. Considering that the patient was coming from a high endemic country from India, are we dealing with a drug-resistant TB? Or there can be a paradoxical worsening of TB following the initiation of the ATT. So before moving forward, I will just stop here for discussion.
Yeah, I think the point here is we were seeing that the patient presented with what was obvious. We were all thinking about TB. He had weight loss, came from India, and that was the obvious thing in mind. And of course, we requested all investigations and gave him a course of steroids in view of the reduction in vision. So the first point here is there is an indication to start steroids immediately because you're trying to salvage vision. And even if you think TB, doesn't mean TB will deteriorate aggressively with a course of steroids, as long as you are proceeding your investigations and you're organizing the chest appointment, which was very quick. Actually, the patient was seen the following day by Professor Omar. So I think the point here is you see the sequence of events. He improved initially because the steroid had a very profound effect on the inflammation, but then he started to deteriorate again. And of course, these are the 2 questions asked. Is it representing the fact that we're dealing with a drug resistant or not? So I think it's important then to see what is happening with the rest of this guy, what is happening to his systemic side. So we had the input of Professor Kohn, and I think we can show some images now of what's happening to him outside the eye. So that is going to give important clues of what is happening to him. So can we move now forward there?
Yeah. So at the same time that the choroidal lesion was progressing, the patient started complaining of headache, and we performed a brain MRI showing this lesion suggestive of a brain tuberculoma. And at the same point, a PET scan was performed showing lymphadenopathy in the inguinal and pelvic regions. So at this point, a biopsy was performed, and since the biopsy did not isolate any microorganisms, the clinical findings were more suggestive of a paradoxical worsening following the initiation of ATT rather than a resistant TB. So at this point, the prednisolone was further increased to 160 milligrams a day.
So keep in mind, this is equivalent to, at this stage, 80 milligrams a day, because you still have rifampicin on board, okay?
The increase of prednisolone resulted in an improvement of the chest CT finding, as you can see here, and also in a stabilization of the brain lesion. However, our choroidal granuloma kept progressing. You can see here the patient was reviewed at 12 weeks, so more than 3 months after starting the ATT, and he was on high-dose systemic steroid. And you can see how the choroidal granuloma was still increasing. So basically, based on the literature showing a local ischemia and also an increased expression of the vascular endothelial growth factor in TB granuloma, we decided to try the intravitreal anti-VEGF approach.
So just stopping a second there, just one point. So if you go back 1 slide, so essentially what we're dealing with here, a very large lesion in the choroid, and we know granulomas are avascular structures. So there's no vessel inside a granuloma. But what is happening, the larger the granuloma gets, the more likely there's being internal ischemia. And the VEGF expression is exactly to try to attract vessels into the structure. And of course, in this case, it is a reason why that lesion was getting bigger. It was causing a leakage, was even involving now the retina. You can see a small hemorrhage involving the retina overlying that lesion. So there is an element of a very large granuloma having a component of ischemia, which then generates this VEGF drive, which makes the lesion grow. And so it's another paradoxical situation in which you are doing everything else in the body is responding, is getting better, brain is stable, and brain is another, is not showing resolution, but stability, but the eye is deteriorating. So we then went on to this idea of, which is not our idea, but we felt it was the right moment to use it. So you can move now to that.
Yeah, so the patient received an injection of anti-VEGF, and you can see here how the lesions show a progressive decreasing in size, but this is better demonstrated by the EDI or CT, where you can appreciate the reduction in the choroidal granuloma. So our take-home message are consider the possibility of a paradoxical response in cases of deterioration of the TB granuloma following the initiation of ATT. And then our question for you is, can the size of the granuloma affect the penetration of ATT and explain the incomplete response to our treatment? And also consider intravitreal anti-VEGF that can represent a useful alternative in cases of poorly responsive TB granuloma.
So we have this issue. We had a discussion with our guru in TB, which is Professor Gupta in Chandigarh, and we discussed this case in similar cases that she has seen. And essentially, we have these questions about the drug penetration being a factor, but the issue is the granuloma is a very effective way of containing spread of an infection. That's why it develops in that way. It's a question of these other aspects of the inflammation that may be connected to this ischemic aspect, which in this case illustrates very well. The injection of the anti-VEGF had a profound impact on the size of the lesion and the amount of leakage that was surrounding it. So Adnan, I'm not sure if you want to expand.
Just one very quick question. So, I mean, obviously the sequential nature of the cases suggests that the treatment has been highly effective, but is the hypothesis for anti-VEGF that it's causing ischemia and then a local vascular response? And then the anti-VEGF works on because it's compressing the choroid, or what's the hypothesis?
No, I think what is happening here is the granuloma, when it becomes very large, you can imagine the central part of the granuloma is where you're going to find the necrotic components of the granuloma. It is the bigger the granuloma is, it's more likely that the central parts of the granuloma are going to become more ischemic. And what happens, you start then having a VEGF drive from the cells which are in the granuloma, the epithelioid cells in the granuloma. So they will start secreting VEGF as a way of trying to bring vessels into that structure, and that establishes a high level of the VEGF around that area. So it makes the whole expression of the VEGF, the manifestation of VEGF surrounding the lesion with the hemorrhage that we saw, the edema and all that. So
I was just one last comment, because we have to move to the next case. I was just wondering if that was possible, would you change, because it's quite evenly hypo-reflective in the granuloma, and would you hypothesize the center of the granuloma of the OCT would alter its reflectivity? Are there any clues in that? I'm probably going to have to leave it there to keep on time, and maybe we can carry on that discussion in the Q&A. So the next talk is from Senthil Selvam. To IVT or not to IVT, the noes have it. A very cryptic title that hopefully we'll understand shortly.
Good evening. I would like to present a case of a 47-year-old gentleman that was referred to the medical retina clinic with a presumed diagnosis of a left central retinal vein occlusion. Visual acuity was 624, best corrected in the left eye. However, the patient had no visual concerns. Bilateral posterior capsular cataracts are noted in both eyes. An OCT performed on arrival of the left macula found significant macular edema with associated exudates tracking towards the optic disc. OCT of the right eye was normal. However, on fundoscopy, there was no evidence of peripheral diabetic retinopathy or retinal vein occlusion in either eye. Instead, we could see evidence of peripapillary whitening and disc hyperemia in the left eye. Concerned about the possibility of peripapillary choroidal neovascular membrane, a fluorescein angiography was performed. The early transits show signs of disc hyperfluorescence with peripapillary hypofluorescence corresponding to the areas of whitening shown on fundoscopy. The late images confirm leakage with mild leakage seen at the fovea. An ICT angiography was also performed, which showed a similar picture of peripapillary hypofluorescence in both the early transit images and the late images. In taking a history, it became apparent that the patient had previously been treated with radical chemoradiotherapy for a paranasal sinus carcinoma 2 years ago, and that his diabetes was secondary to prolonged steroid use. Therefore, a presumptive diagnosis of radiation optic neuropathy was made, and he was referred to the neuro-ophthalmologist, who saw him a few months later, by which stage the vision had dropped to 160 in the left eye. And now on fundoscopy, as you can see, that there is significant worsening of the exudation. No significant deficit in optic nerve function could be elicited, and blood work was found to be normal. An MRI brain and orbit with contrast found the optic nerves to be normal. However, there was increased signal in the optic chiasm. There has been some debate as to whether this is evidence of radionecrosis of the optic nerve. These findings were further complicated by the fact that the patient was known to have post-papilledema atrophy in both eyes. The most recent OCT scan shows improvement of the macular edema, but worsening of the exudation. On his most recent review in clinic, the left vision is now counting fingers, and this is severely affecting his quality of life. In an effort to improve his vision, he has been offered a trial of intravitreal Avastin to the left eye. Points for discussion include whether the vision loss is secondary to the neuropathy or the maculopathy, and whether anti-VEGF treatment is likely to have an effect on his vision. Thank you for listening.
Thank you, Senth. Jose, you've written, we've discussed in the past about radiation effects on the retina, the choroid optic nerve, and you've written extensively on this. So maybe if I could ask you to comment on this case first.
Thanks. This is a great, I mean, all the cases have been great, and the fellows' presentations are wonderful. So let's go to the ICG of the choroid. And here's the thing, or even the fluorescein. Go back. Oh, this is good. Yeah, this is fine. It's silent, and the problem is the radiation literature is really bad. First, they said, well, you get radiation problems in the retina if you're above 55 gray. Then they dropped it to 45 gray. Then somebody said, well, 35 gray. And if you're less than 35 gray, you're okay. Well, you know, the problem is it's not a yes or no situation. It's a log dose response curve. It's a sigmoid curve. And some people we showed from our series at Mayo, even at 25 gray, they were having problems. Even at 20 gray, a rare patient had a problem. So it's very dependent. The patient has diabetes. The diabetes happened after the chemo, but if you have diabetes and you have radiation, it's like 2 hits on the eye. That's the first thing that I want to say. And the second, so you have to really talk to the radiation oncologists and tell them, spare the eye. There is no magic point. And the second thing that I want to say is that we talk about radiation papillopathy, we talk about radiation retinopathy, but radiation choroidopathy is significant, and nobody's really written about it until we showed the histopathology recently, and it looks like polypoidal choroidal vasculopathy. And you get areas of dropout like you show here around the disc, and subsequently you get neovascularization and PCV occurring. So it's a very important aspect as well.
Just Jose, just to echo the point, just like people haven't written much about radiation choroidopathy, there's remarkably little about diabetic choroidopathy, despite the histopathology showing a profound effect, and again, a double hit. Maybe go back to the ICG on that around the optic nerve.
I think that's a great point. I think it's a double hit there too. I mean, this is really bad choroidopathy.
Do you think in patients with radiation retinopathy, they usually get choroidopathy in a peripapillary location, and does that help? Is that something you've noted in the past?
You know, it was on patients that had had prior plaques that we started doing the histology. And this patient got a huge hit. Those radiation oncologists gave them a heck of a hit. So this is probably one of the worst cases I've seen.
I'm not sure, Prof. Bird, any comments with the optic nerve and the radiation? You've probably seen a lot of this in early studies. Any further thoughts on this?
I imagine I've seen it, but didn't recognize it. But the radiation had quite steep Bragg curves, and it may well be that the area around the optic nerve received a much higher dose than the area further out.
So are we all happy this is radiation? I mean, I'm not sure, I don't see any retinal capillary dropout on the fluorescein within the limits of the imaging that we have here. And so the cystoid, maybe they'll develop capillary dropout in the macular retinal vessels shortly, but at the moment it looks like a peripapillary optic nerve phenomenon. Any therapeutic approaches apart from what has been tried?
I think the VEGF is definitely something that needs to be done because we don't have a lot else in our armamentarium.
So thank you for those comments on this interesting double hit case potentially. And so the next case is from Graeme Loh and entitled, "Hey Mack, tell the surgeons we have a problem."
Hi, my name is Graeme. I'm one of the vitreoretinal fellows at Moorfields, and I'm honored to kick off the first case this evening. We have an 83-year-old man of South Asian descent with bilateral maculopathy and difficulty reading when he presented to us in 2009, aged 71. He is a well-controlled type 2 diabetic on insulin with mild non-proliferative diabetic retinopathy and has early nuclear cataracts. He has medically controlled hypertension and hyperlipidemia and developed pancreatic cancer last year. This is his autofluorescence from 2009, where we can observe a mixed autofluorescence pattern with a loss of central autofluorescence masking due to reduced macular pigment shown by the red arrows, as well as loss of autofluorescence secondary to intraretinal melanin pigment migration shown by the yellow arrows. Here are foveal slices from his early OCTs. They demonstrate temporal versus nasal asymmetry. The yellow arrows show where there is collapse of the outer retina and loss of inner retinal lamination that is visible at the temporal parafoveal region, resulting in temporal foveal thinning. The blue arrow shows a hyporeflective intraretinal cavity without retinal thickening that can be observed in the right foveola, spanning the entire retina but leaving an intact ILM, resulting in ILM draping. The hyporeflective lesions highlighted by the red arrows correlate to the presence of intraretinal pigment migration, similar to that seen in retinitis pigmentosa. Fast forward a decade to 2020, here is his right OCT that demonstrates increased outer retinal atrophy and vitreomacular adhesion. The pandemic struck soon after this, and the patient was diagnosed with malignant adenocarcinoma of the pancreatic tail. He underwent curative resection in September 2020. The surprise came the following year in 2021 when he was reviewed virtually at one of our digital imaging hubs. His OCT showed the VMA previously noted had now progressed to vitreomacular traction with significant subretinal fluid. In this autofluorescence comparison, you can see a large new area of reduced autofluorescence in the right eye, correlating to the new subretinal fluid. It is worth noting that the macular lesions in both eyes had enlarged in size over the last decade. An urgent face-to-face clinic appointment was arranged. Here is the foveal cut of his wide-field OCT that nicely demonstrates the VMT in his right eye. Now, the patient was completely asymptomatic in the right eye at this time point, maintaining 636 corrected vision with glasses since 2009. He denied any unilateral metamorphopsia or retinal detachment symptoms. His left visual acuity had gradually reduced from 612 to 624 over a decade. The image to your left is the FFA that showed mild late leakage with central masking from the intraretinal pigment. ICGA on the right showed the peripapillary hypofluorescence more clearly than the FFA. There was no evidence of intraretinal or choroidal neovascularization. Careful review of the patient's high-density OCT scans shows a subtle break in the inner retina that leaves an open connection between the pre-retinal space and the hyporeflective intraretinal cavity. Only by switching to fine cuts horizontally can we appreciate a second break in the outer retina, creating a connection between that same intraretinal cavity and the subretinal space. This has resulted in a combined tractional and rhegmatogenous retinal detachment. The patient has been closely followed up since March this year, and at his last visit a few weeks ago in October, he expressed for the first time now having difficulty seeing bus numbers and performing his daily blood sugars. He also has started noticing a few sky-colored shapes moving around his right visual field for the last 3 months. His most recent OCT shows a shift in the subretinal fluid that now involves a larger area superiorly, as well as subretinal fluid superior and nasal to the optic disc. EDI OCT did not show any choroidal thickening or asymmetry compared to the left eye. The dilemma about whether or not to operate is not straightforward. This patient is 83 with no symptoms up till very recently and has unchanged vision in the affected eye. The patient is not pushing for surgery either, yet his activities of daily living are now starting to become affected. I leave you with this final image, with the opinion that PVD induction in a case like this may run the risk of de-roofing the fovea. And with that, I shall now open up to the panel for discussion. Thank you.
So challenging case. So we've got some experts on the underlying disorder, Kathy, Egan and Professor Bird, and my surgical colleague Lyndon. Maybe I could throw it up to them. Maybe start with Lyndon to discuss surgical approaches to this or not, and then maybe Kathy and Alan Bird to discuss the underlying pathology and whether that would alter the surgical decision making.
Thanks, Adnan. Super case, Graeme, and a nice demonstration that fine cuts show you where the connection is. And the other time we see this is in myopic foveoschisis, where we can often track with fine cuts a very odd full thickness macular hole across various sections. I think in this case, the first thing you want to do is make sure that there's no CNV associated with the subretinal fluid, and I think that was excluded early. And then we've got a straightforward full thickness macular hole. It's odd to get a retinal detachment associated with full thickness macular hole, even with continuing vitreomacular traction. And the only group we tend to see it in, and that picture would be great if there was a staphyloma and this was a myope. But nonetheless, that mechanism is shown. I do have pictures very similar in a myope where you've got a full, very fine, full thickness hole with traction and subretinal fluid. So it's very similar to that. And I think in this case, we do see, especially with a short eye, that there is an option here for treatment. Certainly that's a difficult hole to treat, and therefore we would use something like an inverted flap. That is a double inverted flap. One is where the nasal ILM is inverted into the hole or over the hole, and then a very large temporal flap is laid over it. So these are not easy to treat, but there is a surgical option for this. I don't think you need to treat the subretinal fluid, and therefore it's an option. I think in this case, I would have done what you did, which is wait early to see if there's progression, given he is asymptomatic and given he has many systemic comorbidities. But with the progressing fluid and the slow increase in symptoms that he's starting to get, I would consider surgery in this case. I do think we'll be able to get away without posturing. I think a slightly longer acting gas bubble is reasonable. So C2F6 rather than C3F8, which is quite long acting. So I would consider it. I'd put it to him. I think it's feasible. I think this is a tractional full thickness macular hole here, and it's got subretinal fluid because of the previous pathology. And I do think there are ways of increasing the chance of closure and surgically good outcome.
So thanks, Lyndon. I've had to advise on patients with a similar underlying condition with full thickness macular holes, and I had some caution, given the underlying understanding of what's going on in this condition. So maybe Kathy or Alan Bird can comment on what they think is going on in the underlying condition and how this may or may not affect the surgical outcomes. Kathy?
I'd just like to say very briefly to thank Graeme for putting the underlying diagnosis in the title of his presentation. It would absolutely not be allowed at Moorfields fluorescein conferences. MACTEL type 2 is the disorder that Muller cells play a really key role in and maintaining the retinal integrity. And so one of the late stages of the disease is full thickness macular holes, as Lyndon's kind of alluded to. I could pass over to Prof. Bird at this point in time, but one of the classic things we say is that these holes are often large and often difficult to close with vitreoretinal surgery.
So the absence of Muller cells, which are structurally important, is that going to affect the ability or the outcomes? No idea of a successful surgical outcome, because there are no Muller cells.
I'm just wondering, because we see Muller cell stretch and Muller cell problems, but we don't see a lot of schisis in the detached retina, which is odd. And I'm not sure that it makes a particular difference to the primary closure. I think where the published outcome rates for macular hole are always poor. And what we see is that in series where there's an increasing amount of extra steps, either with serum or with double flaps, we're getting a better rate of closure. The second problem comes is that these close and then with further degeneration reopen. So this is something that's not fixable like a idiopathic macular hole. It's something where you have to be prepared to employ further techniques. And so just doing a standard macular hole repair, I think, would fail here and may give you a very large extending retinal detachment. So that's why you choose to wait until he's clearly got increasing subretinal fluid and increasing symptoms. But then I think you need to use all the techniques you have available at your respective hospital to try and maximize hole closure and understand that this may reopen. But he has got an extending retinal detachment here.
That's fantastic. Well, maybe this case will be coming your way, Lyndon. We'll look forward to seeing the post-operative results. And for our last case, we have Supawat Trepatchayakom, a ripper of a case, which is the perfect way to end this meeting. Supawat.
Good evening. My name is Supawat Trepatchayakom from Moorfields Eye Hospital, London. First of all, I would like to thank EURETINA Case Conference for giving me the opportunity to share this interesting case. The case is a 41-year-old female patient with treated myeloma post-chemotherapy and stem cell transplantation since 2018, and she's been in complete remission since. She had end-stage renal failure, and she was on hemodialysis 3 times a week. She had been under monitoring with the hematology team and was on no medication. Despite having no new systemic symptom, she reported having gradual decreased night vision in both eyes over the period of 12 months. She had been referred to Moorfields, and at presentation with us, her vision has dropped to 6/24 in both eyes. We can see from these fundus pictures that she had subretinal hemorrhage and hemorrhagic PEDs bilaterally. Also, RPE rip was noted in the left eye. There was no inflammation, and the visual axis was clear bilaterally. These are close-up multicolor fundus pictures on spectralis. Autofluorescence in both eyes revealed hypoautofluorescence from subretinal hemorrhage and also from RPE rip in the left eye. Close-up autofluorescence on spectralis. OCT macular scan in the right eye showed relatively intact inner retina, subfoveal subretinal fluid, sub-RPE deposits between the RP and the Brooks membrane, and intracorneal hyperreflective foci. OCT macular scan in the left eye showed subfoveal subretinal fluid and the area of RPE rib. Superior cut in the right eye showed hemorrhagic PDs, while the inferior cut showed the presence of serous PD. Serous PDs were also noted in the superior cut in the left eye. Inferior cut in the left eye also showed dilated hallux layer vessels. Thinning and obliterated choroidal capillaries noted bilaterally. Fluorescein angiogram in the right eye revealed blockage at subretinal hemorrhage and hemorrhagic PD lesions. Staining also noted in the temporal macula. Pooling into subretinal fluid also noted superior to the disc. Indocyanine green angiogram revealed hypofluorescence at hemorrhagic PD lesions. Fluorescein angiogram in the left eye showed window defect at the RPE rib and staining in the temporal macula. So I would like to ask the panel if this is a retinal manifestation of a multiple myeloma that we would expect in mind.
So thank you, Supawat. So this is a patient I presented a few months ago internally, but we have some follow-up actually just from, if you hold those slides a bit, just from 2 days ago, post-treatment, just to show the continuing dilemma. So we first saw the patient said they had multiple myeloma and presented with renal failure, but the appearance is not typical of either multiple myeloma, or which is usually large vessel occlusion, or occasionally affects the choriocapillaris and causes serous detachment and small vessel closure, or indirectly versus the typical features of AL amyloid that overlap with myeloma. And when we actually contacted the patient's hematologist, because I couldn't quite work this one out, the hematologist said, well, actually, the renal biopsy showed light chain deposit disease. And maybe Supawat, do you want to describe that in a little more detail? And that really changed the way we thought, because I couldn't really work out why they had this continuous deposit under the RPE. If you go back, if you go back to the OCTs of the patient, yeah. So yeah, the OCT, more zoomed in, yeah. So yeah, so you've almost got this continuous mid-reflective deposit separating the RP from Brooks membrane. This is not something I would have assumed in myeloma. It can occur to a minor extent with amyloid, but we don't really see a vitritis. We didn't see anything on the large choroidal vessels on the ICG. And a light chain deposit disease has been reported to do this and affect the fluid transport across Brooks membrane, and kind of mimics what Alan Bird and John Marshall said may happen in AMD, where you alter the hydraulic conductivity and get serous PEDs, or large, huge PEDs. So that's what we assumed was going on. So we contacted the hematologist, and actually the National Amyloidosis Center, and got them on the treatment, the most aggressive current treatment.
Based on ophthalmic fight.
Yeah, so at the time I presented this patient. In fact, Jose, if you want to unmute, actually sent me the email of this paper, and it was ironically the hematologist who
Based on ophthalmic findings and despite no systemic recurrence, she was
recommended us to go on that therapy. So if you want to show the current appearance post-therapy, it's got some images in August, post-myeloma therapy. My concern was, and I emailed the Amyloidosis Center, that I was worried that the light chains, like in the kidney, bind on to basement membranes irreversibly, and we may stop further deposition, but I was worried we wouldn't clear it, and suggested alternative therapies. So that's the appearance of the hemorrhaging rapidly recovered. But if we look at the OCTs as of 2 days ago, so yeah, if you click on you've got the video at the bottom.
Yes.
So that's the better eye, Jose. Yeah. So it's kind of almost as I predicted, but hoped I was wrong. That the hemorrhaging, amazingly, I haven't quite worked out why you get hemorrhaging such extensively in this, or I presume it's affecting the small vessels in some way, but we've just got a worsening PED. Obviously, I'll throw it up to Lyndon, because when the London project is up and running perfectly, it'd be a wonderful group of patients to treat, because you basically got all this schmutz between the RPE and Brooks membrane, and an artificial RPE with Brooks membrane would be wonderful. But we're not there yet. Jose, thoughts on this now?
Yeah, it's an amazing case, and so many things have come together on this patient. Go to the ICG though.
Yeah.
So there's no question that it's light chain deposition, but the question is, what is the light chain deposition doing secondarily? So like you said, I think this is the plasticizing, as Prof. Bird had written, and you mentioned of Brooks membrane allowing less diffusion. But I think that this now has a pecker component to it. And the ICGs to the right show areas of ICG fluorescence. And so I think there is probably a component of a choroidal neovascular membrane in this. So I would treat that. And then I would ask the dialysis people to make sure the blood pressure is good. They give them anticoagulants for the dialysis. And if there there is choroidal neovascularization, that's important to have them realize you can't have them over anticoagulated as well. So amazing case.
So the other thing she's bitterly complaining of is profound night vision problems. And she presented with night vision problems 12 months before her reading and visual acuity dropped. Again, vitamin A transport across all this deposition all the way across. Now, I didn't do it the first time around just for completeness. Even though she doesn't have obvious malabsorption, we're sending off a vitamin A level, because it's easy to jump to conclusions because it fits in the story. I'm sure it'll be normal, but there is some malabsorption in some myeloma patients. So I think we're kind of stuck. There is a drug called KL101 we've been trying to get that's for AL amyloid that binds to the light chains and causes triggers an inflammatory response that clears it. It's an investigational phase 3 drug. But whether the binding site on light chain amyloid and light chain deposits, which are different because it's a non-amyloid protein, are the same, is what the National Amyloidosis Centre is unclear, but we're a limit to what we can do. There one other case, which I think was from New York, that was similar to this. They injected steroid anti-VEGF with no real response. Well, we're going to try everything, but I'm open to any other ideas in the chat or otherwise after this meeting. So just to have that rip of a case to finish off, I want to just thank the EURETINA for hosting this meeting, and hopefully this will be the first of many meetings. Can I have the closing slide, please? The panel for wonderful discussion. Thank you for your time on a Wednesday evening. And most importantly, the fellows, and this is a small representation of the wonderfully international fellowship program we have here. There are over 30 retina fellows from all around the world, and it's very much similar when I was a fellow, and hopefully this is just will be attractive to potential future fellows listening in to come and apply. So I'm going to pass the baton in a month's time to Frank Holtz. He'll be doing episode 2, series 1, being hosted from Bonn, and has a fantastic panel to hopefully discuss some equally challenging cases. And on that, I'll say good night to everyone and thank you.
Thank you very much.
Good night. Thanks.